it is my distinct pleasure to introduce the first speaker of the day, Dr. Colin Franz. Colin is a very good friend of mine and many of yours, and we know him from his last year. He was also the moderator for the clinical session. And Dr. Franz, I'm going to read this just to make sure I don't miss any point. So Dr. Franz is a physician and a scientist, and he's at the Shirley Ryan AbilityLab at Northwestern University, and he sees patients at the Lois Insolia ALS Clinic. And his clinical subspecialties include neuromuscular medicine, electrodiagnostic medicine, so this is very important, and neuromuscular ultrasound. So he's the director of the Electrodiagnostic and Regenerative Neurorehabilitation laboratories at Shirley Ryan AbilityLab. And his laboratory team makes highly technology-oriented approach to precision neurorehabilitation. So Colin is a very technology-driven and innovative researcher. And this will, I think, come up from his presentation today. And of course, we know him as a scientist, and he's Canadian, so that's also a very good thing, right? He's very funny and approachable. And he also shared one of his photographs with me when he was a child. And he shared with me that he wanted to be a paleontologist once, and he loved the dinosaurs, and he still does. And he's a father. He's a very good father. And he received recently Sarah Baskin Award. He's also a very good scientist. So being a good person and a good scientist helps motivate us all. And I'm very happy that Colin is together with us today. And I would like to introduce him to give his talk with the title, The Clinical Importance of Motor Neuron Degeneration After Spinal Cord Injury. Thank you so much.
Thank you, Dr. Osdindler. And I'll make a couple comments to start. And I really can't thank you enough for that generous introduction and the thought that you put into it. Obviously, it shows, and it shows since I've been here since 2014 was I came in 2012, but 2014 was the first time I attended the symposium. At that point, I was a trainee here, and it was my first real connection with the neuromuscular group, both the researchers and clinical group there. I was connected with CJ Heckman at the time, and still trying to find my way, actually doing a lot of stuff on nerve repair, and hadn't yet gotten back to doing anything related to motor neuron disease or ALS. So I think that this has an important impact on campus, and of course with people from 20 different countries here, patients and researchers. It also has a big importance around the entire ALS community, clinical and research. This is my first time here giving a presentation as a scientist, which again, thank you, Dr. Osdindler, for the invitation and for always being so supportive of me here even early on. I wasn't really supposed to be here in a sense, and I'll tell you why. I was hired to work at the Rehab Institute of Chicago, and which is now the Shirley Ryan AbilityLab, and to do nerve injury and nerve repair work, which was kind of the way they had envisioned me coming in. But I had fought, and I think because I did the neuromuscular fellowship here with mentors, like particularly instrumental during that year, my program directors, Dr. Driss and Dr. Sadiq, really keeping me and my interest in ALS alive. I did a lot of work on nerve regeneration as a PhD student. I actually did ALS work for a couple of years as a postdoc before starting medicine. I was with Nick Boulis at Emory because I was interested in gene therapy for ALS and cell therapies. It was, when I came to Chicago for my residency and for the research years I put in there, it was because I knew that the Rehab Institute at the time was one of the best places for rehabilitation medicine. And of course, they collaborate so much with the ALS clinic here, with technologies that we offer patients. And then, of course, I knew about, at that time, having worked with the SOD1 animal model of ALS, Dr. Sadiq's pioneering work. Actually, Dr. Brown as well was involved with identifying not only the SOD1 gene as the first genetic cause of ALS, but also developing an animal model, which allowed me to first start working on ALS as a scientist before I even had a direct connection to it, with knowing patients and so forth. So these things are all just thoughts I had off the bat in terms of why I'm here. And then my talk, although I'm going to try to make some connections to ALS, is going to be on how motor neurons generate after spinal cord injury. I have no disclosures on this work. I'm going to give a quick introduction to the subject linked with like some clinical work. I'm going to sort of take on the identity of a bit my clinical persona here and talk you through some of the things I see in clinic and this reverse translation that where we get ideas from what we do clinically that helps inspire our research work. I'm going to really tie it into this new interest I have, not just on nerves in general, but on nerves like the phrenic nerve that go to the diaphragm muscle and its functions, and as well as how genes and trauma can interact, that it can be relevant for both spinal cord injury, and I'll make some connections to how this might be an interesting and is interesting in ALS. Oh, 1 second here. Okay, so we're going to start with the case of 2 patients that I was taking care of or helping to take care of who were mechanically ventilated after spinal cord injury. I was consulted and they wanted to know about the diaphragm muscle health. And I had one patient who was 50, they're both on the rehab unit at the same time. One was a 15-year-old patient who had a neck fracture and a spinal cord injury from a motor vehicle collision. And this is an ultrasound of his diaphragm, I'll talk about in a second. And another patient who was a 12-year-old female with a neck fracture and an injury from a gymnastics injury. And what I could tell you, these are hard to look at, I know, if you're not used to looking at ultrasounds, but we're looking in from the side of the rib cage. I'll explain it a little bit more in a subsequent slide. We can see a couple ribs here. We can peek in between the ribs and actually see the diaphragm muscle, which I have highlighted here between these 2 markers. And we can measure things like its thickness or its ability to contract. And this muscle in this patient here with the 15-year-old was not contracting at all, but we could clearly visualize it. And in this patient, we saw a similar looking muscle, but it had just a little bit of, this is called thickening ratio. So it increased by 20% during breathing. And I'll show you some examples of how this looks. And I'll explain to you what this has to do with our topic. I'll also try to monitor some of the Q&A that comes in, but I'll get to that at the end, I promise. So as an aside, so how we assess the diaphragm, particularly in this age, because this during the epidemic has really been challenged in ways that we didn't anticipate a few years ago, is ordinary breathing tests can generate aerosols. And of course, that's one of the ways that the coronavirus can spread. So it's become a bit of an issue in terms of making these tests as universally available that involve aerosol generating procedures. So ultrasound is, I'm not going to go through the whole mechanisms of COVID, but we have been doing a sort of through the amount of neuromuscular complications we've seen in COVID, we've been using these approaches a lot in these patients, the same ones that I'm using in spinal cord injury clinic. And as an example, some of our work that came out this year on how diaphragm dysfunction can occur after severe COVID using ultrasound, which was a nice follow-up study to a study where they had actually gotten tissue from autopsy patients who had died from COVID, showing fibrosis of the diaphragm, and we showed it through our imaging technique, and also some refinement so that actually, although this doesn't sound that relevant to ALS, but this diaphragm and phrenic nerve ultrasound protocol that we're describing here, thanks to Dr. Deshmukh, who helped establish this at Northwestern, is the same protocol now that we can offer patients in our neuromuscular clinic. And that the impetus for kind of making this more available on campus, and there's not that many universities that have this well developed, has been through the pandemic, but it's benefiting our neuromuscular community. Let me show you. So this technique, Andrea Boone at the Mayo Clinic, who's a physiatrist there, works in the neuromuscular group, has really helped pioneer, where you can basically look at the diaphragm muscle. It's the main muscle of breathing. And I hope people can see I'm just pointing out the diaphragm. It's like a dome shape here in that image on the left. And you can actually, through the lower rib levels, peek at it through the ribs with an ultrasound, so not invasively. And as it turns out, this is one of the best possible tests for how diaphragm function and diaphragm health, because comparing it to other types of testing, including electromyography with needles, which can provide perhaps the gold standard, but also comes with a risk of collapsing the lung, although it's small. This is a very safe test and very easy to do. And the diaphragm, I sort of compare, when you saw those pictures earlier, we'll see them again, to like a layer cake. So you have a connective tissue layer in blue, a connective tissue layer in green, the diaphragm's in between them, and there's a little line in between, that's a tendon. And so that's how I explained it to the residents. So it's actually, with a little bit of training, not that hard to learn. And so this is what a normal diaphragm should do. I have this a little overexposed. There's a rib. The diaphragm is in between these lines, and there's the bright line there. Actually, the lung peaks down. We call that peeling, and that's a thickening there. So this is a really easy bedside test that a patient can watch. You can see the muscle activate, contract, and then relax. And that's what a healthy diaphragm should do. So what I'm telling you is neither of those diaphragms were changing in thickness very much. This one, not at all. This one, just a little bit. And they're both about the same thickness, which could take my word for it. This is about the lower limit of what we consider normal. They can get thinner in certain situations when there's severe nerve injuries. So the first patient, we looked at their diaphragm. It's not thickening. This is that number. It's the same thickness with the breath in and with the breath out, and it's just still. And so this patient has an intact connection to the diaphragm, but can't control it because of the spinal cord injury. In other words, an upper motor neuron lesion. So what we do with these patients, and I'll go through this in a second, in a few more slides, so everyone's getting the concepts. But we can actually, because he's mechanically ventilated, we want to get him off the ventilator if possible to prevent things like pneumonia and other complications. So we can actually place stimulators onto the phrenic nerve, and that will contract the diaphragm for a patient like this, and often gets them off, if not for the whole day, for long periods of time where they can be free of the ventilator. And what this looks like, this is a patient, we were just trying to make sure that we could activate the diaphragm. So watch the diaphragm move here when we did it, just a test stimulation here in our electrodiagnostic lab. So you can see every time I stimulate them, ordinarily they can't contract this muscle. Every time I stimulate it, boom, 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 it contracts. So this patient was a good pacing candidate. The other patient who had that little bit of a twitch, we checked in with her again in a few weeks. And boy, when we started doing our ventilator weaning protocol or liberation protocol, Dr. Wolf is involved with this at Shirley Ryan too. And what we could see is the follow-up scan for this person was, this is the thickness with the breath out, this is the thickness with the breath in. You could see that it's almost doubling now. So the muscle now is a much stronger contraction. And this patient was actually able to have their tracheostomy removed and be unhooked from a ventilator. And we were able to make this prediction with the testing we did at bedside, which is a huge thing because it prevents a lot of complications that can happen when you're hooked up to these machines if you don't have to be. In contrast, another patient I didn't mention up front, but this is what we can find, which is a bit of more of a problem. And this is a diaphragm marked here with these two markers here. This is the lung. This person's on a ventilator, and just watch, they have a very thin diaphragm. I think you can appreciate it compared to the other two. It's not going to contract, and we're just going to see the motion down of the lung, peeling it off the chest wall with every mechanical breath. And this diaphragm never contracts. And this patient remained on the ventilator. So those are three different potential outcomes here when we evaluate these patients. Fortunately, we don't get that many patients like the patient who couldn't be taken off the ventilator at all. But it does kind of bring back this circuitry, which I think is relevant as well, thinking about ALS, where you have a cortical spinal tract with an upper motor neuron and projections down to the spinal cord. Of course, the lower motor neurons in the spinal cord, which both of these cells are involved with ALS, can degenerate also in spinal cord injury. The spinal cord injury usually is a transection of these wires coming down, but what's underappreciated here is at the center of the epicenter of the spinal cord injury, you can have a lot of degeneration of motor neurons that can cause a lower motor neuron condition. And if it's around, for example, the phrenic motor neurons, which go to the diaphragm, it can cause irreversible paralysis of the diaphragm or the hand, et cetera, in the neck region. And so that would be an example. And then below that level, usually by a few segments, you can have relatively normal spinal cord tissue, again, just disconnected from the brain. So paralyzed, but not under volitional control. So I will make the point that both spinal cord injury and ALS are diseases of the upper motor neuron and lower motor neuron. Both can result in muscle paralysis. ALS, of course, being progressive, while spinal cord injury generally does not progress or have, although there can be some complications chronically. And neurotrauma is clearly the cause of spinal cord injury. Well, in many cases, we can have atraumatic injuries from cancer and et cetera, but in terms of what I'm talking about, but in ALS, trauma is not clearly a cause, but may be a risk factor in some patients, and that's a controversial subject. And we had, in fact, I'm not going to spend a lot of time on today's talk on that because we have some other ground to cover, but something that we had reviewed just a couple of years ago, the potential link between head injuries and ALS, which is an area that could deserve an entire hour spent on it, at least in the future. But the interesting thing too, and I think Dr. Osdinler can sympathize, is that in the spinal cord injury world, no one appreciates how important the lower motor neuron injury is, although it can have important ramifications. And in ALS, I think sometimes we have to remind people that in addition to having the lower motor neuron problem, there's an upper motor neuron problem. And some patients who mostly have upper motor neuron problems, and that sometimes is underappreciated. And so what does an upper motor neuron diaphragm look like after spinal cord injury? Well, this is an example of that, a muscle that's not thinned out, not atrophic, but doesn't contract. And this is what that kind of looks like on an ultrasound scan. Trying to breathe, trying to take a breath in, but not much of a result, not much of a contraction there between those two lines. Just poor activation. What does a lower motor neuron diaphragm look like? I already showed you, but just to remind you, it's that really thin one. It doesn't move either. It doesn't move either, but it's really thin. And this one is an important distinction in terms of because pacing a diaphragm will not work in that situation, but it may work on the upper motor neuron. So motor neuron death after spinal cord injury, it's not that I'm the first person to bring up the topic, but I like to focus on it a lot more than most of my colleagues. And I'm inspired and sort of validated by some of the work. This is the late and great Christine Thomas from the Miami Project to Cure Paralysis. And she had an interesting paper. She had worked there for most of her career and did a lot of interesting research on spinal cord injury. One of them, where they looked at patients who had just passed away who had had a spinal cord injury, demonstrated this issue about how variable the spinal tissue can be affected after an injury, traumatic injury. So this is a normal spinal cord. This is the ventral horn here on one side and the other side, zoomed in. And then you compare it to some of the patients they autopsied, where this is one spinal cord that's really hard to recognize the anatomy at all. It's very scarred. This one has a very affected and cystic side, and then a less affected side, another one. Just showing you the range of pathology. And here there's some motor neurons here in the ventral horn. This one is just mostly gliosis and lost cells. So what they did is they counted this, and I'll take you through their work, but they found that lower motor neurons do degenerate after spinal cord injury. The extent of the degeneration is highly variable, and some variability, of course, is due to the type of injury that they had, what caused it, how much force, or the age of the person perhaps. But the variability, and this is just looking at the data from Christine Thomas's work, from the E is the epicenter of the injury. They match people with different levels of injury, and going a couple levels above and a couple levels below, you can see that it craters out at the center of the mechanical forces, of course. When you average out, there's 7 patients, and then there's less injuries, but you have to go a few levels. So you can lose multiple levels. The spinal cord can be affected with lower motor neuron degeneration after spinal cord injury. But then if you break it down by patient, then this is where the variability comes in. Each of these lines representing a different patient. You can see some of these patients are severely, severely affected, some in the intermediate, and then other people, for whatever reason, very little loss of motor neurons. And so that raises the question, at least in my mind, and perhaps because I'm influenced by ALS and the work in ALS genetics, is that could genetic susceptibility be implicated here too, in terms of why this is so variable? In other words, are some people more resilient or more vulnerable based on their genetics? And there's some early work being done on this, and a little bit in clinic, more in preclinical models. And won't focus too much on these individual genes because I want to tell you a little bit about some of our data, but I will point out when you look at this from a review paper that looked at some of the potential genetic modifiers of spinal cord injury outcomes. Some familiar candidates like ApoE, which is ApoE4 allele, increases the risk for Alzheimer's. Doesn't necessarily cause it, but increases the risk. We see some genes that are familiar to people in the ALS community, SOD1 and TB43 as trauma modifiers. And those are disease genes that if mutated at certain sites can actually cause ALS. Another gene, SEP9, which is linked to another neuromuscular disorder called neuralgic amyotrophy. So we do see this, see some of these implicated in modifying spinal cord injury outcomes, and a bit of a convergence of our fields, if you will, between people who focus motor neuron disease from ALS versus motor neuron degeneration from spinal cord injury. So the gene we have been focusing on, I have to admit, I kind of got tuned into this by Jordan Grafman. He's a well-established brain injury researcher at Shirley Ryan, and he had a very unique data set on Vietnam veterans where they had identified this as a gene that modifies the outcomes from traumatic brain injury that those patients had. And what really interested me about it, looking at it, it's just a single nucleotide variant in the brain-derived neurotrophic factor gene, which is one that's very important for motor neuron health. And it's just a single site where you have this base pair that's can be altered, and this is something that doesn't affect the mature BDNF protein over here, but the pro domain of the protein, so that it influences when the protein's actually finally processed and secreted, it's normal. And what it does is, not only is BDNF important for motor neuron survival, and that's very well established in development and in certain injury contexts, it can be carried about, this polymorphism, unlike some of the other mutations, is extremely common. 30% of the population of the US and have carried this genetic variation. And of course, it doesn't cause spinal cord injury, but if it's a modifier of the condition potentially. And it's at any given time, you would predict about a third of our patients in the hospital would be carrying this potentially important genetic variation. And it is linked to other rehab populations, including stroke and brain injury, in terms of modifying their outcomes. So it seemed like a very important place to start. And so how do we, and then the other reason that's interesting to me as a rehab doctor is it doesn't just influence like I said, the BDNF protein is basically normal, but it doesn't get processed appropriately inside the cell. And so there's two ways it's released. One is through a constitutive release mechanism where it's sort of releasing BDNF at a steady state most of the time, and this is coming from a neuron. But there's another way that neurons can release BDNF, and this can be related to activity. In the case of a spinal motor neuron, we think of exercise, and that pathway is very blunted and disrupted in the people who carry this polymorphism. So they release BDNF one way, but not the other. And they have, generally, we think, lower levels of BDNF available. So what we did is using induced pluripotent stem cells. So these are stem cells we can generate from patients and reprogram into neurons of our choosing, as opposed to other ways of modeling disease. We were able to generate these cell lines using CRISPR-Cas9 editing, create versions of the cell lines that only vary by the presence or absence of this polymorphism from two different people. One person was a carrier of the met allele, and one was not a carrier who did not have that variant. And then we make motor neurons from them, all the different cell lines, and we compare them. And this allows us to do more cause and effect types of studies in a tissue culture model, but that's human tissue as opposed to what's possible with just clinical observation. So the first things first, we showed that both of the MET carriers, the one that was modified to be a MET carrier and the one that was naturally a MET carrier, make less BDNF compared to the ones that don't carry this gene variant, which is nice because this was the one part of this variation that we can all agree on. They should make less BDNF. So we seem to have a good model. So we wanted to go ahead and study how injury, like mechanical injury, can influence survival of these motor neurons. And through collaboration with John Fine at the University of Illinois in Chicago, he's basically built us a version of this robot that he has in his lab that you can put a tissue culture plate growing your cells on top of it, and you can ram it from the bottom with these posts. And these posts will stretch the plates up, or we can leave out areas where there's no posts where they don't get injured. And we can compare this stretch injury to this uninjured well and see if there's and we can induce trauma and have controls in the same plate. And this is just an example of one of the custom-made plates that has a flexible silicone rubber bottom to allow for this stretching. And so this is where we grow our neurons. We take these neurons and we put them in this plate so we can put them on this machine. And this is just a picture's worth 1,000 words. So this is just an example of one of the stretch wells. There's a stretchable electronic arrays, which is from a separate project, but they show that it sort of on the pulse up, they get stretched, and then when they relax, they fall down. And this all happens in 30 milliseconds, very rapidly. So what our basic approach is here is we differentiate these motor neurons from the stem cells, from the patient stem cells, or from human stem cells. We wait 48 hours after we put them on this tissue culture plate, and then we apply our stretch injury. And then after 3 hours, we assess for viability of the cells. And so our hypothesis was that the carriers of the BDNF MET allele, those motor neurons will be more vulnerable to degeneration. And so when we look at them under a microscope, when you don't injure them, which we call sham, both the genotypes MET or VAL, so this is the gene that we're interested in that we think may have a negative impact. When we grow them here, they both grow lovely neurites and are happy in the dish. But then when we injure them, and this is just a milder injury, we can see evidence that there's fewer cells here compared to the other genotype. And when we looked at mild and more severe injuries, and we quantified it across multiple different experiments, and I apologize that we don't have the number here, but this was with each line, we did 3 different experiments with 20 different wells, some stretched, some unstretched. So we had a lot of replicates by our standards. And what we found is with no stretch, there's no difference in their survival and in terms of our neurotoxicity assay, but with a low stretch and with a high stretch, we see selective vulnerability, more vulnerability of the MET allele carriers against the VAL allele carrier. So like the ones with the genetic variant are more susceptible to this mechanical injury in both cases. And this is unpublished data, so apologize. This is a little bit unpolished, but we've been really interested by these results, and we think that since they're likely related to this impaired release of BDNF, well, maybe we can just rescue this effect by adding back BDNF. And we added back a little bit of BDNF. You can see 0.1 micrograms per milliliter, and we seem to rescue this effect. So the MET carrier, which was more vulnerable, when we add back BDNF, we see that there's less of an injury response. When we add back higher amounts of BDNF, we don't necessarily any further benefit, maybe a bit of, although it wasn't significant, a tendency for them to do a little worse. And this is fairly well established with some of these growth factors, including BDNF, that it's a bit of a U-shaped curve where you get a benefit, and then if you have too much, it can be have a negative effect or not give you any additional benefit. But we're still open-minded that maybe there's more going on here than just the lack of BDNF, although we have kind of these results which are quite interesting and fitting with our hypothesis. So we also did some uninjured cells. We just looked at gene expression profiles with RNA sequencing.
Colin, I don't want to disturb you, but you are into your question and answer time.
Okay. Yeah, so I'll just finish on this because this is very preliminary. Yep. That we upregulated 613 genes that were specific to the MET carriers and downregulated 878, and then there was about 36,000 that didn't change. And when we looked at those, we saw in some interesting categories, including cell adhesion molecules, and in particular, we sort of jumped out at us that downstream signaling pathways for that BDNF pathway, including AKT and MAPK, were altered, and that was sort of stuff we're working on validating now. But we're seeing very good evidence that that this effect seems to be driven in part by the BDNF signaling pathway, but perhaps there's some other areas that we can focus on for future experiments to better understand this and have implications for precision medicine. And that's where I sort of make the point in summary that you can have a group of people that all look the same, that all start off the same, but maybe you have their unique features. You have two people, I took these two guys, one with his hair parted to the left and right, that could be carriers of a certain gene variant A versus a genotype B. And you expose them to the same injury to the neck, and one of them may have a different outcome than the other, and perhaps that this gene is the reason for it. And so essentially you have the same injury, but different outcomes. So trauma is definitely not a genetic disease in the sense that the gene causes your spinal cord injury, but these genetics can influence the outcomes, and perhaps one of these patients ends up with a healthier diaphragm than the other. And that's sort of the hand waving here at the end, with the take-home point that motor neuron degeneration after spinal cord injury is an important problem, that there's implications for patient prognosis and predictions of outcomes in rehab, what we do surgically and for rehabilitation afterwards. And I think we can learn from ALS and vice versa in terms of how motor neurons health is important for both diseases, upper and lower. And I will just make the point, and I apologize for eating into my question times, that I'm really grateful for all the people I work with in the ALS clinic. Missing from these pictures, I believe, Dr. Osdinler and Dr. Sadiq as well, and some of the other team members, but this is a lot of our crew here, including the Skinnis lab and my lab, who I couldn't do this without. And I'll just highlight Dr. Finan at UIC, who's been very helpful in this collaboration, and Suning He and Maria Kazeta, who've done a lot of the work I showed you.
Colin, thank you so much for starting with such an exciting topic. And I think you mentioned three things, if I heard you correctly. First, you mentioned about the images that you showed us with the diaphragm muscle. I don't think correct me if I'm wrong, I don't think if they have been used as an outcome measure in any of the clinical trials, like if you can improve the health of the diaphragm muscle, because this is very important for the breathing, right? And then your study with BDNF, that's also very important. You also mentioned the personalized medicine approach, right? So can you put your work into context, projected to the future? Like, let's say if there was no limits in funding and then sky was the limit, and how your research would translate into clinical trials, and how would it make ALS patients' lives better?
Yes. So on that latter point, I did include, let me just see if I can march my way back up a couple of slides here. That's going that way. Oh, perfect. Yeah, it just froze for a second. One of the ideas I wanted to put forward, without being too hand wavy, because we haven't done exactly this, but these ideas are out there. This is stealing from Alzheimer's disease research. Is you come into your clinic with patients who may or may not have disease. You diagnose patients with disease. You then have a situation where you want to get every patient with ALS or other neurodegenerative diseases involved in research and clinical trial opportunities if they're interested, and so that they can be as engaged as possible, especially when you don't have cures. And so now the question is, can we run clinical trials differently? We're already doing things where we use one control group and testing multiple drugs, but what we're not doing enough of yet in our field is identifying biomarkers that would indicate that a patient might respond to different drugs. So for example, in case of breast cancer, that you have your genetics tested and it may influence the type of treatment that you get, and the same in terms of hormone therapies, et cetera. And the same thing potentially is a possibility for ALS patients, depending on, do they have a genetic cause that's a very clear one, then they should be in a gene therapy. We have gene therapies coming up for C9 and SOD1 that are already making advances. Do they need to have another pathway that's disrupted in their particular form of disease, targeted more precisely? And that might lead them to treatment, in this scenario, say treatment B versus treatment C. And I think that this is where we'd like to see the field going more and more. It's not a trivial amount of work to get there, but that's one of the things that I think may help address some of the issues with failures or responses to treatments that are less impressive when we average them out, but we see individual people who have better responses. That I think comes up frequently.
We have a couple more questions. If you could answer them briefly, that would be great. Here, Pavle Anjus, he asks if there are any similar data on VEGF other than BDNF on VEGF? And Hank Chupi asks, how does spasticity affect the diaphragm in upper motor neuron disease patients?
Okay, great questions. So with VEGF, so we focused on BDNF around this variant that causes a deficiency in those particular people who carry it. And so we corrected that deficiency. There's been work on other growth factors, including BDNF for just all ALS patients. There's been phase 3 clinical trial on just giving it systemically, and then one where they gave it to the CSF, and they did not see on the aggregate protective effect. It missed its primary endpoints. VEGF, there's been preclinical work on that as a therapeutic for ALS, and of course IGF-1 also went to clinical trials, and people have been interested in GDNF. And so, but simply just adding back the recombinant protein to everyone, it doesn't seem to be an effective strategy. So that's where we kind of get into, could you tailor it? Like some people may be BDNF deficient. Can we identify those people? And maybe that's one of a combination of things that could be part of the treatment. Of course, I'm using a lot of conjecture here because, but we know that the trials where they just add back one growth factor to a bunch of patients don't seem to be curing the disease. And so we need to think about what we can learn from them and maybe not totally throw away the baby with the bathwater.
All right, thank you so much for your
and
answer.
the spasticity question we'll talk about maybe in the clinical panel. Thank you for the questions.
Yes, yeah, maybe we can
opportunity.
answer some of the questions in the clinical panel as well. Thank you so much, Dr. Franz, for your participation, for your talk. Thank you so much.
Thank you.